I'm going to talk for the next sort of 10-15 minutes and give you a bit of a whistle-stop tour of emergency oxygen therapy in adults. And I suppose this is either the more mild end or the more sort of moderate end of the COVID spectrum, or perhaps the initial management of those severe patients with patients with severe COVID-19. And then Ed's going to talk more about the ICU side of things. And a lot of the principles here are really generic principles that apply to all patients, but where there's relevance, I've tried to link them into COVID as well. Okay. If you're on Twitter, you can follow the Tea Time Teaching Twitter account there, and we'll crack on. So Blair's already mentioned Devon Ambulance, the link's there, we'll share it again at the end. Please do support them if you can. Just a reminder that the series aims to introduce some of the fundamental concepts relevant to COVID-19, including both the physiology and the management strategies. But we're not trying to give you guidelines or definitive advice. This is a rapidly evolving field, so things change, and please do follow your local guidelines and recommendations. And finally, the presentations don't reflect the opinions of the contributing institutions. So, a quick whistle-stop tour of oxygen therapy. Here's what we're going to cover. I've been warned that my internet connection's a little bit patchy, so I will try to make sure I speak clear and recap things. But if at any point you're struggling, please do let me know. So what we're going to try and do in the next 10 to 15 minutes then is discuss elements of targeted oxygen therapy, talk a little bit about flow rates and FiO2, and then talk a bit about oxygen therapy in the context of COVID-19. So the initial basis for any patient needing oxygen therapy is to start with a really thorough assessment of their breathing state. And I know we've got different groups of professionals and student professionals on this webinar, and you'll have different ways of doing this, but it ultimately all comes down to making that B element of your ABCDE assessment really thorough. And that includes looking at the observed findings you see in your patient. So are they in respiratory distress? But also those measurements that we can use a bit more objectively as well. So what are the patient's oxygen saturations? And importantly, what's the patient's respiration rate? And that's something that often gets missed out. But actually we know that resp rate is the one component of a news score that's most predictive of the patient's inpatient mortality. So counting a resp rate, if you take nothing else away, is a really important thing to do. Okay. So when you assess patients' breathing, one of the things you'll do is record their SATs. The other thing that you might do if you're worried about them is to do an ABG, and we'll come back to that in a minute because that's something that's going to really direct your oxygen therapy. So everything possibly you want to know about emergency oxygen therapy, and then some more, is available in the British Thoracic Society guidelines. And these were first published in 2008, but there's an updated version from 2017. It is 100 pages long, and what I'm not going to try and do in the next few minutes is tell you everything that's included in there. But it's definitely worth, perhaps not a full read, but a flick through of the key bits in there, and there's a really good summary at the end. Interestingly, the first line of that guideline I've put up on the left here, and it says very clearly that oxygen is a treatment for hypoxemia, not breathlessness. And this, I'm just going to go back a slide. And that's a really important thing to remember, because oxygen is there to treat patients with low oxygen saturations, not patients who are breathless. So in the context of that COVID-19 patient who, like we talked about last week, might be very hypoxemic, but actually doesn't look breathless, they need oxygen. But the patient who looks breathless but has normal saturations isn't necessarily going to benefit from oxygen. So in the context of mild or moderate COVID-19, that's worth remembering. There are some exceptions, for example, patients who've had carbon monoxide poisoning, but generally treat people's oxygen saturations. That's particularly important in the current climate because we're going to be using a lot of oxygen around the hospitals. And interestingly, there was something I was reading in preparation for this talk about how much oxygen is available in different emergency departments. I mean, it really varies. So a modern emergency department might have about 2,000 litres a minute available. But older departments might only have 200 litres available per minute. So if you have 14 patients on 15 litres via a non-rebreathe mask, that's your oxygen capacity for the department. So it's worth remembering that oxygen is a treatment for hypoxemia, and for your patients with normal SATs, it's not going to help with their breathlessness. So we mentioned briefly an arterial blood gas, so taking a sample from the radial artery in the wrist, and this is really useful because it gives you a very quick indication of a patient's oxygen partial pressure and their carbon dioxide partial pressure. If you're struggling to get saturations, this is useful. We know that SATS probes aren't always reliable. Something I thought I would just highlight while we're talking about ABGs, something from those guidelines actually, is that the BTS recommend local anaesthesia for ABGs, something that isn't always done, but actually makes the procedure significantly less painful for patients. And perhaps it's one of those things that when we're in a busy time like we are now, we've got lots of patients coming through our department, it's easy to let those sort of little things slip, but actually they're the things that make a real difference to the patient experience. So something just to think about. Okay, so oxygen therapy, the big question, of course, is how much, because we know that we can deliver oxygen to patients at different quantities. Okay, obviously, the thing that's going to kill somebody first is hypoxia. So, if in doubt, more oxygen is generally the right way to go. Hypoxia is the life-threatening thing, but we also know that hyperoxia, too much oxygen, can also be damaging. It can cause damage to blood vessels in the brain or in the heart. And it can promote the creation of oxygen-free radicals that can cause further damage. So really what we want to do then is take a Goldilocks approach to oxygen therapy, and hopefully this is something that most of you will be familiar with. And typically we would talk about target saturation ranges, either 94 to 98 or 88 to 92. That changes a little bit in the current climate, and I'll come back to that again. But again, the Goldilocks principle we're going to stick with. So in order to achieve that, we can give oxygen in different ways. And generally there is a sort of a stepwise approach to giving oxygen. And you can, if you have a patient with a low oxygen requirement, you would start at the bottom step. But if you have a patient who's quite sick, you might start part way up that. Okay. So nasal cannulae is the most simple way to give oxygen in a low dose. And the guidelines say that actually for patients with suspected COVID-19, a surgical mask can be placed over that nasal cannula, and then they're less at risk of passing on an infection to other people. Beyond that, we have a Venturi mask, so that's these coloured adapters that you can see, and they deliver fixed flow rate, fixed FiO2s, that we'll talk about in a minute, and we'll talk about why Venturis are great shortly. You then got a non-rebreathe mask, so something you're familiar with here, and that you would put 10 to 15 litres of oxygen through a minute, and that's the highest amount of oxygen we could give through a normal modality. But there are other ways of giving oxygen too. So high flow nasal oxygen is something that people might be familiar with from the intensive care unit. So they typically give anything from 20 litres of oxygen a minute upwards via what looks like nasal cannulae, but gives a lot more than your standard nasal cannulae. That is an aerosol generating procedure, but also oxygen can be given through a nebulizer, which importantly isn't an aerosol generating procedure. And then obviously if you've got a patient who's on CPAP, who's being non-invasively ventilated or invasively ventilated, we can provide oxygen there. We know that these different modalities give different quantities of oxygen, but actually something people sometimes struggle with is to quantify how much oxygen we're giving. And that's for a reason that I want to explain. So some people you will hear talk about oxygen in terms of the flow rate. So the number of litres, the number of litres that are being administered per minute. You'll also hear people talking about the FiO2, or the fractional percentage of inspired oxygen. Okay. So the flow rate is simply what you turn the dial to and what comes out the wall or the cylinder, and the FiO2 is the percentage of the air the patient's breathing in that contains oxygen. So in room air, it would be 21%, and if you were breathing 100% oxygen, well, it would be 100%. Ideally, what we should do is express that oxygen requirement with the FiO2 rather than the flow rate wherever possible, and I'll quickly talk about why in a minute. FiO2 is really useful because we can use that when we're then interpreting something like an arterial blood gas. Okay? And while the FiO2 is a percentage, conveniently we can very easily convert that into a partial pressure. And that's because the pressure of one atmosphere, so room air around us, is 100 kilopascals. So if you're breathing in 21% oxygen, 21% of 100, so the pressure is 21 kilopascals. So using a fraction of inspired oxygen makes it very easy to work out how much the partial pressure of oxygen is. The actual conversion is 101, but 100 means we can do it very easily. And if you think back to our oxygen cascade that we talked about on the second talk, if we know the FiO2, then we can work out the inspired partial pressure of oxygen. Then very quickly it gives us an idea of what we're expecting to see when we do an arterial blood gas. So this is why I would strongly recommend that wherever possible, you use an FiO2 to express oxygen delivery rather than the number of litres. You can convert the flow rate to the FiO2 with a chart like this, but it's important to remember that these conversions are approximate, and actually for a fixed flow rate, the FiO2 as a percentage can vary considerably. And this is because that percentage depends on how much the patient is ventilating and therefore how much air they're bringing in from around them. So if you think of a patient who's getting 15 litres, say, via a non-rebreathed mask, there's 15 litres of oxygen going into that system each minute. Okay. So if the patient's minute ventilation, so the amount of air that they're breathing per minute, which is a product of the tidal volume and the respiratory rate, if that's also 15 litres, then we can roughly assume that they'll be breathing 100% oxygen. The problem comes, of course, when the patient's respiratory rate goes up, when they start breathing more. And if the amount of air they're breathing per minute goes up above 15 litres to 20 or 30 litres, suddenly that 15 litres that's going into the mask isn't going to give them 100% oxygen. It's going to give them 90 or 80 or 70%. And so the sort of fallacy of this is that the more unwell the patient is and the more they're breathing, actually the lower the FiO2 is likely to become. So this is why with a non-rebreathe mask or nasal cannulae, you can never be 100% certain of what the actual percentage that the patient is getting of oxygen. The advantage of a Venturi mask is it works in a slightly different way, and so it does allow you to do this. And we'll talk about that now. So hopefully you're familiar with a Venturi mask. There are the little adapters. They come in 5 different sizes. They're color-coded. And what you do is you pop it onto a mask like this, and it says on it quite clearly a number of litres a minute, and you put that number of litres of oxygen through the mask, and it will deliver a fixed FiO2, which it says on there. Important to remember that if you turn the oxygen flow rate up or down, you won't be able to titrate the oxygen on this in the same way that you would with, say, a nasal cannula. There's some really clever physics behind this, but essentially just remember that if you follow the instructions on the adapter, it will give you a very reliable FiO2. Okay. And so why is that? Well, very, very quickly, what you're doing in the Venturi mask is having a system a bit like that you can see on your screen. So you've got oxygen being tubed into the mask and air being brought in from outside through these little holes that you can see on the adapters. And what that means is, regardless of whether the patient's minute ventilation goes up or down, regardless of how much of that mixture they're drawing through, the oxygen and the air will be drawn in at a fairly consistent ratio. And that means that unless the patient starts breathing above, say, 30 breaths a minute, then you can get a very reliable FiO2 from the Venturi. So I would argue very, very strongly in favour of using Venturi, particularly if you want to be able to accurately monitor a patient's oxygen requirement and any changes in that. There's a really nice little illustration here that talks, it's from Rebel EM, and it talks about the graded approach to oxygen administration in patients with COVID-19. Obviously, some patients will present in extremis or very sick, and you maybe wouldn't start with nasal cannulae as it suggests here, but for most patients you can start low and titrate up, and there's a move away from going for the sort of more invasive, certainly aerosol generating procedures in the emergency department because of the need for more PPE and ideally a negative pressure room. So your trusts will all hopefully have their own guidelines on oxygen administration, and I would strongly advise that you follow those. But a sort of a graded approach here is what I'm trying to illustrate. Okay. So a few things about COVID-19. Obviously, we've talked last week about the fact that COVID-19 causes inflammation in the lungs, how it presents with a type 1 respiratory failure picture. So hypoxemia is the primary problem. Interestingly, there's been some guidance from NHS England in the last couple of weeks that's actually suggested that for adults in hospital, rather than be aiming for our normal target range of oxygen saturations, we should aim for 92 to 96%. So that's a little bit lower than we would normally tolerate. But the justification for that is that it will help to conserve supplies of oxygen. And there is lots of evidence that actually aiming for that slightly lower target range is not harmful to patients. Within that document, which I put a link to at the bottom, they've suggested that if hospitals are really struggling, that a slightly lower range below that could even be targeted. Obviously, for our patients with COPD, we would still use a lower target range, so 88 to 92%. If a patient has an increasing oxygen requirement, that's a marker that they're deteriorating, and it's really important to pick up on that. So using a Venturi where you can accurately monitor the FiO2 is really useful. Okay. I'm not going to talk too much about when you would escalate beyond that, because again, you'll have local guidelines and you just need to be familiar with and follow those. But for example, if a patient was on the top end Venturi, so a 40% or a 60%, and after 30 get them to those target sats, that would clearly be a reason to consider getting support in for further interventions. And then proning, I'm just going to talk about in a second, because I know we discussed that last week. But the Intensive Care Society has suggested that if a patient has an FiO2 requirement over 28%, then you might want to consider conscious proning. So I'm just going to show you some resources there. Again, I'll send the links to these so you can have another look in your own time. But this is new guidance out in the last few days from the Intensive Care Society. So their guideline on when to consider conscious proning is on the left side here. But what I really like is that they've made a little guideline for patients, or a patient information sheet, explaining to patients a bit about the idea of conscious proning that's on the right-hand side there. So I'll send you the links to that afterwards. So a bit of a whistle-stop tour there, as promised. Sorry it was a little bit rushed, but hopefully we can give Ed some time now to talk about intensive care, which I'm really looking forward to. I know there was a bit of time pressure, so what I have done is put lots of links in here to areas that you might find useful, and I'll make sure that I post them in the discussion so that you can follow those links too.